Hello, good evening.
Hello, sir. Welcome, sir.
Yeah.
Yeah, sir. Presenter is joining.
No problem. We'll wait for some time. Thank you.
Yeah, sir. This we are uploading in the residents group. Yesterday you were asking me.
Yeah. Residents group, huh? The Telegram or in WhatsApp, is it?
For this current batch 2025, there is one separate group of residents. In
Only
that
residents
we
are allowed
are
in that. Okay.
yeah, we will upload in Telegram group also, sir. We'll
Okay.
say share the
Thank,
link.
thank you. Yesterday, Ramanan, he said he will upload some article from which he prepared the presentation. He didn't share that article. From some article he prepared.
Yeah. I will ask Dr.
Yeah,
Ramanan.
it's okay. Thank you.
Yeah, and Dr. Dhanya has prepared with the that she has shared that
Yeah.
gate, different types of
Yes.
gate.
Yeah. Thank you.
That PPT she has modified and shared in
Okay.
the group.
Very good.
Yeah. If some time is there, then in next presentation we'll see that.
Okay.
Dr. Raman, he was saying that he will find the article and share.
Yeah. Okay, Ramana. Thank you.
Dr. Rohit is online.
Maybe he will join. Actually, other Zoom meetings, the moment we log in, it will take into the board. This one, so many, every time it is asking for password, meeting passcode and all. Usually, Zoom meetings we have attended earlier. The moment we click into the Zoom link, it directly takes into the platform. This one, I think, I don't know, like it is asking every time password, separate password, not our this meeting passcode. This is
Okay,
special Zoom, I think.
don't know. Maybe some settings have changed
Yeah. Thank you.
after this AI and all.
Yes.
Dr. Rohit is joined.
No, I'm not seeing in the list.
Yeah, I will call him.
Dr. Ajay Kumar Biswal is asking for upload approach to myopathy, neuropathy, PPT of previous scholars also. I think Shailesh has to answer.
Hmm.
Dr. Ajay, if you are in the resident group, you might be getting that. I think you are not in the resident group, I think. If you're in the resident
Yeah,
group,
I will check again and we'll upload
yeah.
all the classes.
Yeah.
Actually, we are sending at that time only, and YouTube link also we have shared.
Okay, we have YouTube link for this.
Yes.
Okay.
Sir, Dr. Rohit here.
I don't see in the list of the participants. I don't see his name.
Sir, am I audible?
Is it Rohit? RP?
Yes, sir. Rohit,
Oh, okay, okay.
KP.
Yeah, yeah, okay, okay. Go ahead. Yeah, you are
Good.
audible.
Okay, just 2 minutes, sir.
Yeah,
Like I've
share your
logged in through.
PPT.
You shared, sir. Okay. So, like, I'm not able to see the slides.
Okay, your name is Zoom user. That's why. Dr. Akash will send you the PPT. Can you
Okay.
project his PPT once?
Yes, sir.
He is presenting through his mobile, so he has some problem. So, Dr. Akash, can you share his PPT?
Rohit.
Yes, I'll do it. Sir, actually, I am also on a mobile phone, but I'll share it. So,
Oh,
is it visible now? Hello? Is
No.
now
yeah,
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 it's
yeah.
visible now. Yeah.
visible? Wait, wait, I'll mute myself and then fine, I can start. Let's start.
Okay, okay. We will
Slide,
start the session.
slide.
In a, Dr. Ramnan, you are on laptop?
Sir, no, sir. I'm also in mobile phone, sir.
Okay, okay. We'll start 1 minute. Okay, we will start today's session. Dr. Sheikh Afshar Pasashar and Dr. Soumya are today's moderator, and Dr. Rohit is presenting today's session on case presentation. So, sir and madam, you can introduce yourself, followed by Dr. Rohit. Then we'll start.
Yeah, I am Dr. Shekhar Pasha, moderator for this session. For this evening, we have a case presentation by Dr. Rohit on cerebral system examination.
Good evening, all. I am Dr. Soumya and welcome you all for today's session. Doctor, please start your presentation. Am I audible?
Yes, yes, madam, you are audible.
Yeah, ma'am, you're audible. I'll start.
Yeah, please start, Doctor.
Yeah. Thanks for this opportunity. I'm a final year DRNB resident at Apollo Hospital, Seshadripuram. Coming to my patient particulars, he's a 40-year-old gentleman hailing from Basveshwar Nagar, Bangalore. He's a BE mechanic. He studied up to BE mechanic. He's working as a IT manager at a biochem firm. He presented with, he's a right-handed. He presented with chief complaints of imbalance while walking since last 3 years and difficulty in speaking, which was since 3 years. History of presenting illness. My patient was apparently all right 3 years ago when he started noticing that he's been having imbalance while walking in the I mean, which was insidious onset, and it has gradually progressed in severity. This imbalance while walking increases during night time and in dark environment, and while walking on uneven surfaces, and he has swaying towards either side while walking. Presently, he's able to climb staircase up, has difficulty climbing down. So he's not able to come down without holding on to the guide rails. And he has difficulty walking fast, and he's not able to run. And he is having difficulty negotiating narrow passages. At about 3 months after the onset of difficulty in walking, bystanders noticed that the words spoken by the individual were not pronounced correctly, and they were having difficulty in identifying what the individual was speaking. This was a complaint the individual told regarding difficulty in speech. So, otherwise, coming to the negative history, there's no history of smearing food while having food. No history is suggestive of motor weakness, or no history suggestive of cranial nerve involvement, or no history of any abnormal movements. There's no change in handwriting or signature, no history of giddiness. He doesn't give any history of any systemic symptoms in the form of fever, joint pains. There's no history of medication intake for any other illness. He doesn't give any history of any intoxication. Past history was nothing contributory. Personal history, he consumes a veg diet, and bowel and bladder habits are normal. Appetite is normal. He consumes alcohol occasionally. So family history, he says that his father had similar complaints of walking problem at the age of 40 years, and brother had similar complaints which started at the age of 30 years. Ultimately, he expired at the age of uh, 35 years. And mother's brother and the mother's brother's son also had similar complaints of walking difficulty. So to summarize, a 30-year-old gentleman with complaints of ataxia and dysarthria of 3 years duration, with significant family history of multiple family members being affected with similar complaints. So functionally, the individual is having ataxia and dysarthria. My anatomical localization is cerebellum and its connection. And etiologically, likely is genetic, like genetical cause is the likely etiology in this individual.
Dr. Rohit, please go back to the first slide. We'll go by symptom. Huh?
Yes, sir.
Madam? Yeah.
Yes,
So,
sir.
yeah, please tell
On
the
to the
first symptom.
first slide.
First
First
slide.
slide. In patient particular, is there any thing that you are missing that you must tell in your neurology cases?
Right-handed individual, age, occupation,
And language.
language.
Language is must. You must tell. Sometimes you won't be having a patient who is unable to tell you because there's language barrier. So that is
Okay,
must.
okay,
Okay. You have a
okay.
person who can speak multiple languages, single language, so it should be there in neurology. Okay.
Okay, okay.
What is language, Dr. Rohit?
It's a form of communication of ideas.
What is speech? What is language? What is the difference between the two?
The speech is the articulation. Language is the process by which an individual communicates with
You're
each other.
right. Language is UMN, speech is LMN.
Okay.
Language is produced by the central cortical centers. Like you have Broca's, you have Wernicke center, you have so many centers are there, no, for the language production. So it's a means of communication by which a person is able to produce sound. And what you said, speech is as an peripheral executory apparatus. It's an LMN.
Sir.
Speech is an LMN apparatus. Okay.
Yes,
So,
sir.
okay. So why is it important language in a patient? I'm asking language. Why is it important?
Like dominant hemisphere we'll get to know by I mean, by sidedness we'll get to know the language or the speech
Through
center.
language or through handedness?
Sir, yeah.
Which one?
Uh,
How do we get to
handed,
know the language localization? By handedness or vice versa? How?
like handed wise we'll get to know the language side.
So in a person with right-handedness, you have language centers
On the left side,
predominantly located on the left hemisphere.
90% of the time.
Yeah, that's why dominant hemisphere, we say dominant, non-dominant hemispheres based on the handedness in the individual. If you say it's a right-handed, dominant hemisphere is left side because language is located on the left
The
side,
left side.
predominantly.
Yes.
Okay. Okay, so non-dominant hemisphere means right hemisphere in right-handed individuals.
Yes,
Okay,
sir.
go ahead. Next slide.
The imbalance while walking of 3 years duration and difficulty speaking of 3 years duration, sir.
His age is 40. You said
40-year-old.
problem started
3
about
years ago.
3 years back. So age at onset was
37.
37. Okay. And the first symptom was imbalance
Imbalance
while
while walking.
walking.
Yeah.
Imbalance, what you have written? How did you deduce the information on imbalance? Go to the next slide. Imbalance, what are all points you have written? Imbalance to suggest, not just see, even though we are discussing about a cerebellar case, we need not point to write all the points in favor of cerebellum. We should approach how we approach. How do you approach a case of a person who says imbalance while walking? Okay. So what are all the points you have written here?
I mean, started imbalance while walking, insidious, gradually progressive. This imbalance is such that he sway towards either side while walking. This swaying towards either side increases during night and dark environment and on while walking on uneven surface.
So what you're trying to convey that swaying towards either side while walking.
So well, like then acute onset.
Yeah, go ahead.
So in acute onset, it can be like one-sided swaying depending on particular site involved. In case of a chronic thing, it can be a chronic condition leading to ataxia. It can be either side swaying. There's no particular preference.
What can be? What is that acute? What is that chronic? You are not completing the statement.
Sentence.
Complete the sentence. What is acute? What is chronic? Acute vestibular ataxia you're talking? Acute sensory ataxia you're talking? Acute cellular ataxia? What is that acute? What is that chronic?
Acute is one which starts within minutes to hours.
Imbalance in walking can be due to many causes, like it can be visual, vestibular, cerebellar, sensory, frontal. Okay. So what are the features of vestibular ataxia? How did you differentiate vestibular ataxia from sensory ataxia versus cerebellar versus frontal?
So, see, vestibular will be one is acute onset. There will be a premonitory, usually post-viral infection, and they'll have other ear-related symptoms in the form of a tinnitus or hearing impairment.
Okay. The most common vertigo condition what we see in clinical practice is usually BPPV, benign positional paroxysmal vertigo. Okay.
Yes.
There you may not have the classical, what you say, oral symptoms. Okay. What we say, deafness, tinnitus. Okay. So what are the other features? What you see in a patient with vestibular ataxia?
One is the acuticity and some tinnitus, ringing sensation in the ear. Then
Most important point. The ataxia
Positional,
worsens
sir.
at the movement of the head movement.
Positional. Yeah,
Yeah.
while sleeping, if this turn towards either like one side, the vertigo or giddiness will be there. It is positional.
Mhm. So vestibular ataxia is due to what? Involvement of what structure in the brain?
The vestibular nerve nuclei and the
Vestibular.
inner cells of the
So it is in the brain.
this thing, sir, vestibular nerve in the
Uh-huh.
inner ear.
Is it in the brain? That's what we call. It is not brain. It is outside the
It's
brain. It is
peripheral
said
outside.
peripheral. It's a peripheral ataxia. It is not central. Okay.
Yes.
What else you see in a patient with vestibular ataxia? You see something, the eye sign, prominent eye sign.
They'll come with diplopia.
Okay.
So
Yes.
nystagmus is
What is the characteristic of nystagmus in vestibular ataxia?
horizontal one-sided
How is the fast
rotatory
component?
nystagmus.
How is the fast component?
Fast component is towards the unaffected side and slow component towards the affected side.
Fast component is away from the lesion
Lesion.
in vestibular ataxia. Okay.
Hmm.
What do you know? Okay. How are the features? What are the features of cerebellar ataxia?
Cerebellar ataxia, they'll have basically incoordination while walking. They'll get swayed towards one side or bilateral.
Mhm. Now, in your patient, which part of the cerebellum you're talking about? You said swaying towards either side while walking.
Sir,
Which part of the cerebellum is likely to be involved here in your case?
usually the central vermis involvement causes this swaying towards either side, where axial involvement.
Mhm. What is the difference between the ataxias of cerebellum due to Vermeer involvement versus antelobe and Vermeer involvement versus vestibulocerebellar involvement? What is the difference? Both of the patients have truncal ataxias. They have gait ataxia. How do you differentiate?
Predominant axial involvement is there in case of vermis and appendicular
Very good.
involvement in
Okay, very good.
flocculonodular cell.
So patients
one
having
point.
midline, you said Vermeer's mean midline. Patients having truncal imbalance, truncal attacks, gait ataxia, truncal tremor, trunk shakens. The trunk moves to and fro, and patient may have titubation. Okay. In anterior lobe and Vermeer, whereas vestibulocerebellum, falconoidal lobe, they have multi-directional body sway, severe impairment of body, severe impairment of body and truncal movement. They cannot be able to sit and stand. Okay, they veer to the ground, either right or left. Okay. However, if you make the patient lie down, their functions will be normal. Okay. They'll be able to do heel to shin test. Their upper limb functions are relatively preserved in patients with vestibulocerebellar involvement or falconoidal involvement. So in your case, with imbalance while walking, with swaying to either side, suggestive of involvement of which part of the cerebellum?
So pan cerebellar, more of central.
Pancerebellar. What is mean by pancerebellar?
Like both
Midline,
the midline
hemisphere,
and
everything, all come at once. Unlikely, right? There will be some, even though their incidence is gradually progressive, it means it would have started in one side, then progressively involve the other side, or both limbs started having simultaneously. Even though they are degenerative disorder, they have certain, when they onset itself, they may involve one, then progress to the other side involvement. Need not be that they are all together comes at once, right? Bilateral, simultaneous, symmetrical, all at once coming is
unlikely.
Unlikely, right? The patient cannot
Yes.
overnight. If someone comes overnight, you are sitting in OPD or in emergency, someone was brought and said, sir, he slept yesterday. The moment he got up, he was having veering to the both sides, not able to stand, not able to sit. What do you think? Do you think hereditary
Mm.
ataxia?
No, no, it's
What do
a
you think? What do you
acute vascular.
Yes, it's something acute problem related to
Mm,
either a peripheral vertigo due to benign positional paroxysmal vertigo, or could be a vascular, could be an ischemia, it can be hemorrhagic, something
yes.
acutely, all
Mm,
at once
mm,
coming. Okay. So,
yes.
but your case is 3 years history
Um,
of long duration, started slow, progressive, slow, but you said
mm,
only one statement, swaying towards either side while walking. That's
mm,
all.
mm.
You should have described. You should have some more information is required. Your history is very, I say, very less. What does it mean?
Yes.
Other you said increases during night and dark environment.
Even yes, more difficulty.
What is the
Uh,
difficulty?
the swaying increases when he's in a dark environment or is trying to go in a.
Hmm. No, what does it do? What is his profession? You said. How does?
He's a IT professional working in a biochemical
What do you say,
bio.
Soumya madam? Soumya madam?
Yes, sir.
What do you say? Like this history, I feel it is very
It's very
short and
incomplete,
compact.
sir. It's very incomplete actually for ataxia. I mean, it's like a short case, not even a short case.
Uh,
Yeah.
he has written very like bullet points, like only one or
Mm.
two with a background family history, and he said it hereditary actually. It should have been more elaborated history. We should have.
Yeah. So actually, in case of ataxia, you should at least tell what part of a body is involved. The first thing, whether it's only the lower limb, whether it's a truncal involvement, or he is having head involvement or not, or upper limb involvement or not. That should come here only. And along
Oh,
with that, if you are saying that he is having swaying to either side, so whether it just started with the swing or was even having initially unsteadiness on the narrow paths, then developed onto the broad areas or the crowded places also. Was there any associated vertigo? Or was he having
Mm,
experiencing any nausea along with that time, or there is a worsening during the night? So whether it's a disproportionate worsening, see in all the ataxia, what happens? Your brain is having the the constellation of the areas are given for your balancing. It's not only the cerebellum or that. You are
mm,
having
mm,
visual information. You are having your vestibular information, cerebellar information, proprioceptive, and then finally frontal. So five, six things are actually causing you to walk normally. So if you are just removing a one part, definitely you are going to worsen because they all are causing what summation.
mm,
Okay, so all the ataxias worsen during night, but in sensory, it's a disproportionate worsening. So you have to ask them whether it's just a normally worsen or if there is some disproportionately you just get a difficulty. And not only the night, you will ask them, do they experience wash basin phenomena? And if the people are doing their this puja and all, so at that time, as soon as they close their eyes, they start feel swaying at that time also. So that thing should also come.
some
And for
okay.
day-to-day
today,
activity should have added, Rohit. Some day-to-day
Okay.
activity. What he
Okay, sir.
felt earlier, what was the
Mm,
impairment he felt? How is his daily activity affected? How is his profession affected? How is his family affected? Like bathing, the, you
whether
know.
he is Yeah,
Yes,
whether
madam.
he's
Go ahead.
experiencing any falls or
yes.
not during because of that. Did he experience any trauma? Was and someone was telling him that as if it looks drunk all the time, or along
Mm,
the same time, not only the balance or the speech. Actually, in a ataxia patient, there are a lot of the impairment they encounter, so that should also be told.
ma'am. I mean, he
Yeah.
doesn't give any history of vomiting or giddiness during this episodes of swaying that I had mentioned regarding
No,
giddiness.
see
No,
the
not
And
just
swaying.
day-to-day
vomiting, Mister.
activities, he's able to walk, but he's not able to walk fast or he's not able to run. And
So that
climbing
that
staircases and all, I mean, up is able to, then he's now having difficulty coming down, for which he is using
why he
guide
is
rail
having
support.
difficulty in coming down? Why he is having
Mm.
difficulty?
What is the difficulty?
Yeah.
Look,
Do you think does he have proximal lower limb weakness?
it
Proximal
is
muscle of lower limb is weak. That's why he's coming.
not
What are the muscles
historically
which are
doesn't give
useful in climbing down? What are the things which are useful in climbing down? What are the muscles?
Mhm.
Climbing up, climbing down. See, in exam, questions can come like this. When your
So,
history is so vague, we are not giving the proper information. The examiners may go this way, that way. Whatever you tell,
so,
they drag you that side. Don't mind, huh? We are asking
It's
like
okay.
this. Please don't mind.
Mm,
I'm just telling you, like I'm giving the sense of in exam, if you write like this kind of history, they will drag you
mm.
to multiple directions.
So,
You said climbing stair up. Okay.
Eh,
So what are the muscles helpful in climbing up? What are the muscles helpful in climbing down?
so-
Why did you write this climbing history here? Usually we write this kind
okay.
of history in patients with the LGMDs, myopathies,
So,
myotonia. So, sir,
maybe,
we write mastenics, LEMS. There we write this. Here, what is the point you are trying to draw in conclusion?
like how is it affecting his day-to-day activities?
Okay.
That
Okay. What
the
is your
point
inference
we
after
would
this,
try
right?
to
What is your inference after writing this line?
say. I mean, inference, just baseline status, patient, whatever history he gave, we had
Mm-hmm.
kept that. So.
Yeah, he will tell whatever he feels like, but we have to
Mm,
ask what we want to derive the information from the, which is useful information. We have,
mm,
as madam so rightly said, and we initially asked, there are 5 to 6 things which are helpful in for locomotion: visual, vestibular, sensory, proprioceptive, and frontal, cerebellar. We have to ask points in favor, against about the history in
so,
every case. That history should come up in the case file. We would like to see how you are trying to exclude other parts of the neuroaxis, how you are narrowing down to cerebellar and its connections. That's what we
so,
want to see in the history.
mm,
That is missing. That's what I feel. Huh? Don't mind. Huh?
okay.
Actually, currently it looks like that your patient is having all three.
Hmm.
It's looking like he's having cerebellar. Along with that, there's a worsening in the night and
Hmm.
during this night time also. So it looks like sensory also.
Hmm.
And along with that, it looks like he's having motor problem as well. The
Hmm.
proximal
Hmm.
muscles are also weak.
Hmm. Hmm.
Mm,
So I mean, it's not clear from the history. So the few points should be added in localization from the ataxia part only. Okay.
okay.
Yeah.
Right, ma'am.
Now in the speech, please tell us what are you?
Mm.
What information do you drive?
So speech, yeah, the words spoken were not pronounced correctly, and bystanders are having difficulty in understanding speech or words.
Okay. So why do you think it's a speech problem, not a language problem?
He's able to communicate. I mean, he's able to speak, ma'am.
Oh no,
Just
no.
that
I
is
mean,
the words that is speaking or not.
the person with Wernicke's aphasia, they also speak, no? But
Mm,
how do you say that they are having a language problem? They are aphasic rather than you say that this is just a speech
he's
problem.
speaking. I mean, he's speaking coherently, like whatever
Yeah.
asked for,
So
but the pronunciation is.
So the first thing is we will say that the patient was speaking, he could make the sentences, he could understand what others were saying, but when he
Mm,
was trying to speak, his words were not clear and there were no uses of any new word in that. And the naming
no.
was also normal. Whenever he would like to ask, he would call the name. But the
Okay.
comprehension was difficult because either the words are smushed or the words are too loud or they are. I mean, you have to tell. I mean, speech what kind of speech your patient is having, whether he's having LMN speech, whether he's having UMN speech, or your patient is having cerebellar speech. So those words should come in history also. I mean, you won't say
Okay.
that much that you are
Mm,
going to say in exam or the examination part, but those words which drive in. I mean, currently you can't say from your history 2 lines what kind of speech your patient is having. Okay, so is there any nasal
okay.
twang or not? Is there any nasal regurgitation? Is there whether he is having difficulty in deglutition at the
Mm,
same time? And one more thing, your patient is having gradually progressive complaint. So just don't write it like directly after 3 months because for 3 years history they don't remember. So just write it
mm.
3 to 4 months. I mean, in the range you write it. Don't write it like exactly months over there. Okay.
Okay, 3 to 4 months or 3 to 5 months
Yeah,
post.
2 3 months, yeah, like that. So because it's a gradually progressive, they won't remember exactly today I started having ataxia, today I started having speech
Mm,
difficulty.
mm, mm.
Anything else, sir?
Yeah. What are the types of speech problems, sir? How do you classify? Like you read Bradley, na? The chapter of approach to language and speech. There are 6 steps of assessment of language. The different types of speech classification. Mayo Clinic classification of speech disorder. Have you read
Sir,
Rohit in Bradley?
yes, sir. That
So even
Benson,
if you remember that, you can easily derive the information in the history. You can write.
yes. Mm.
Hmm?
Spontaneous speech, naming, auditory
Hmm.
comprehension, repetition.
That is for the language.
It is for
For
Mm.
language.
for
Yes, sir.
speech also you have spastic, flaccid, mixed,
Mm.
hyperkinetic.
Hypotonic,
You could have
hypotonic.
written some data about each type of. Sir, I don't feel it's spastic because it's not effortful. I feel
Mm.
it is not flaccid because the words are not so labile. Like nothing is coming in history. You
So,
felt that it is hereditary ataxia, and you are convincing us by saying family history is there, and he's having ataxia, he is having some dysarthria with background family history. Take that it is granting that it is a hereditary
mm.
ataxia. The examiners won't accept Rohit like this. They won't
So,
accept at all. They want you to check your knowledge of neurology, not just cerebellar neurology. They want to check your understanding, comprehension of patient's symptoms, and narrating down the symptoms to exclude the other parts and concluding to the focal neurology of cerebellum and its connections. That history is missing, my dear.
okay.
Please
Mm.
improve. Huh?
Mm.
Next time you have to present. Huh? Don't forget that we are talking like that. Next time you disappear from the group and you
No,
don't.
no, no. I'll be there.
No,
I'll be there.
you have to present next time another case of ataxia in future. Maybe we'll see after 2 or 3 months. We'll see your improvement. Huh? Yeah, go ahead.
Yes, yeah.
No, go back.
Go back.
No, it's
Go
just
back.
sparing food while eating. What is that point inference? No, it's just sparing food while eating. Where do you get sparing of food while eating?
So,
What about hand?
ataxias,
No.
appendicular involvement, predominant appendicular involvement,
So,
they might
so you
have.
have to say hand-mouth coordination. So,
Sir.
because we are
Mm.
considering this a case of cerebellar, we are talking about, like you
Mm.
check the imbalance while walking, lower limb incoordination.
Mm.
Similarly, upper limb incoordination, how do you check? What are all the questions you ask to the patient to check for upper limb incoordination? When patient tries to eat the food, hand-mouth coordination, right? Like
Yes.
when the person starts eating the food, how he prepares the bolus of the food. Okay,
Mm.
can he able to mix the food within between his fingers? Can he make a food bolus? Can he bring that food bolus to the mouth in a proper, accurately reach into the mouth? Or while trying to reach to the mouth, does he have any tremors coming up? Is there any dysmetria? Is there any asynergia? Is there any discomposition of the movement? On all reach into the mouth, does he spill the food over his mouth or over his shirt? That history, that is very important in upper limb coordination. Okay, that's history. What you're talking is about upper limb coordination. You're trying to say that this patient doesn't have upper limb coordination, right? Rohit, hello,
Yes, sir.
am I audible?
Yes, sir. You're
Yeah, yeah,
audible.
yeah, yeah, yeah. So upper limb coordination in right hand we check like this. How do you check upper limb coordination in left hand? Asking the
Mm.
patient how he drinks the glass of water. We
Sure.
drink glass of water with the left hand. So how
Okay.
does he hold? Can he hold
Mm.
the glass of water aptly with his left hand, reaching out to the glass, or does his hand stops even before reaching out to the glass? That's what called undershoot, or is going out of the glass, what we call overshoot, or after holding the glass, there was a shaking of the hand, is it intention tremor or action tremor? On reach into the mouth, does it spill the in between coming to the hand to the mouth? Does he spill the water out of the glass? And does he pour the water over his body? All this system, all this history is required, Dr. Rohit.
Yes, sir.
Hmm. Upper limb coordination, right hand is checked like this. Upper limb coordination, left hand is checked like this. And buttoning shirts. Does he able to button his shirt or not? Does he? How does he wear his trousers? Like single leg trouser. When we try to wear the pants and trousers, we are supposed to stand on one leg and lift the other leg. So when he tries to stand like that, what is it happening? Can he stand on his own on one leg, or does he fall to the side? Where is that history, dear? What, madam? Soumya, madam?
Yes, sir.
This history should be required, no, madam?
Yes, sir. Definitely, sir.
This history is not there.
And yeah, and even while you are saying that smearing of food is there, after that you have to ask them that whether they are able to prepare the bolus, or whether they are able to chew the food, what
Yeah.
difficulty they're encountering, whether they have to chew it, whether they have to mix it with the saliva, and then while deglutition, do they have any nasal regurgitation or not? Because the speech difficulty is there, no? So you have to check all the lower motor, all the 9th, 10th, and 12th
Why,
cranial.
Rohit? Why, madam, asking that point? To check for those involvement of lower cranial nerves. Why?
This CVJ anomalies and all
Huh?
can
No.
affect.
Tell the localization. No, don't tell that. No, we are trying to differentiate that the dysarthria, dysphagia, dysphonia, whatever. Is it bulbar or pseudobulbar?
The lower
Right?
cranial nerve involvement goes in
No, we
favor
have to
of.
rule out bulbar dysarthria versus pseudobulbar. Okay.
Sir.
What is bulbar dysarthria? Due to pathology within the bulb. What is bulb? Medulla, which contains, as madam rightly said,
Lower cranial
9,
nerve.
10, 11, 12. Right?
Yes.
What is pseudobulbar means?
The bulbar symptoms.
What is pseudobulbar?
Supranuclear.
What is pseudobulbar,
Symptoms
dear?
of this.
Yes.
Symptoms with lower cranial involvement without
It's because of the supranuclear involvement of the same cranial nerve. That means the corticobulbar fibers.
Yeah, you're supposed to read a lot, man. You have to read a lot. Clinical neurology, you have to read a lot. Which book you are reading, clinical neurology?
This thing.
Which one?
Brazil's localization in because
Brazis you are reading.
Brazil's
You are not
because
answering like
of
this.
the.
Oh, Brazis, if you're reading means you should answer well, man. Brazis, actually, De Jong or if that Kadilja's simplified neurology you read first. First you start with a simpler book, Kadilja's simplified neurology. That gives essence of the information. If you understand that book well, then start with De Jong. Paul Brazis, I feel it is very much confusing for a beginner. What do you think, madam?
Yes, sir. The first, actually, you should start with the neuroanatomy,
Yes.
the basic one. The first you understand and what is the neuroanatomy, what are the upper motor, what are lower motor, what are cranial nerves, what muscles are supplied by which part, which cranial nerve, or the which motor system is there, and then you should see that what actions are there for a particular nerve, what nerve is there, or what your
Madam,
motor
tell him
sensory
the book,
system
ma'am,
is
which
there.
book to read for that.
So the simple anatomy book, the first.
Which book? Name the book, ma'am.
Sir, I mean, they can start with this BD Chaurasia only, the first thing.
Uh,
That's
which,
simple. Or then to
or,
go with the D
yeah.
Jones. Or actually, I will just give a hack. I don't know whether to just say on this platform or not. There are YouTube lectures of the name with the Ninja Nerd. So there is just a 15 to 20 minutes lecture is there that will be very good. And then you can go for Vishram Singh or this BD
Who is that,
Chaurasia.
ma'am? YouTube lectures by whom, ma'am?
Sir, there is this US teacher is there, sir. Actually, it's
Name?
both Ninja Nerd is there, sir. The name of channel.
Ninja
So
Nerd.
Ninja Nerd. I mean, it's only for students, sir, not
Hey,
for others.
Dr.
So,
Rohit.
Sir, we have this
Please.
Vishram neuroanatomy.
Dr. Rohit, please note down that. Please go through that. What madam is
so
trying to say, huh?
it's just a 15-20 minute lecture for each cranial nerve or for each system. It is very rapid because the basic knowledge we have, we just need to brush up that knowledge. So you will get a very good thing. And after that, you go with De Jong's anatomy. Okay. So then you will be able to comprehend De Jong's anatomy very well.
Vishram Singh,
Because
one book is there, ma'am. That also
uh,
it gives very good
that is also
information.
good, sir. That is
But
also good, sir. But
yeah.
that visual information, that visual
Yes.
auditory information
Yeah.
goes from
Yeah.
that YouTube.
Yes, ma'am.
Najib lectures are also there, sir, but they are very long and
Very long.
elaborate. They
Very,
don't
very
have.
long.
So
Yeah.
they don't have time now before
Yeah.
exam. So that Ninja Nut will be helpful. You go with the Ninja Nut, then you go with Vishram Singh or De Jong's anatomy, and then you go with the clinical examination from De Jong's first.
Yeah, ma'am.
Okay,
Okay.
Rohit, go ahead.
Next slide.
No history of change in handwriting. What kind of handwriting you get in ataxias, brother?
Sir, if we has associated tremor, there can be coordination issue and
No, what kind of handwriting? Where do you get micrographia?
micrography is seen in Parkinson's disease.
Where do you get the opposite of it? That's what we are talking. Macrographia. Where do you get?
Cerebellar.
That's what you're talking. Okay, go ahead.
Then no history of coming to the etiological for any medication, any alternate.
Where is the negative history? Yeah, negative history.
So no history of medication.
Other system involvement.
See, one thing, in neurology, the first thing, you take a positive history of what systems you feel. Then the negative history should comprise starting from the cognitive. Okay. So from the cognitive, then to your cranial, all the cranial nerves that are involved or not involved, then the motor, then sensory, then cerebellar. What are already case of cerebellar, then cerebellar negative come along with your all the positive cerebellar history. Okay. Then your autonomic symptoms. And after that, any spinal involvement or some you're getting any history or not. Then comes the etiological history.
Okay.
Okay. And again, in your etiological history, as if now if you see, you are dealing with a case who is having chronic, progressive, symmetrical ataxia. Okay.
Yeah,
So
chronic
you know that
symmetrical.
in chronic, progressive, symmetrical ataxia, if you see for the Harrison's classification, there are certain disorders or the certain questions you should ask for that disorder. So you start from where? You start from the degenerative. Then you start along with that, you'll see for paraneoplastic, for the celiac, for thyroid disorder, for endocrine disorders. So
Yeah,
that
ma'am.
stream should be there.
Nothing of history of related to these disorders you have written.
Yeah.
Just remember the mnemonic vitamin D, vascular, infective, trauma, autoimmune, metabolic, neoplastic, and then degenerative. Just remember this mnemonic. Remember what are the causes from this on the acute. Remember what are the causes from this in chronic. And in that, you have to take your history and you have to tell your negative history in exam. Okay?
Yeah, ma'am.
Now, the past history should not be written like nothing contributory, right? It has come detailed. There is no history of vascular risk factor like hypertension, diabetes. What all you ask, no? So that should be written. Don't write it like this.
Okay. No,
Something you
All
should
the
fill.
medical, surgical, all history that we ask in our MBBS days, no? The same you have to write it over here.
no history of diabetes, hypertension, past history of TB, or no history of any previous surgeries here.
Yeah, trauma. Trauma also. Trauma is very important. Why?
Very, very important.
Head injury leading to a cerebral hemorrhage or
Cerebral hemorrhage head injury won't cause no for the next 3 years progressive ataxia. What happens after cerebral injury?
the glyos,
After head injury, what is the condition when you will get this?
just pugilistic.
It's a superficial cortical siderosis. Very rare condition, but may
Okay.
get. That causes this chronic progressive ataxia.
Okay.
Okay? Okay. And in personal history, again in the diet, it's a vegetarian, but you have to tell whether they consume milk or not. Whether in the because in India it's not a pure vegetarian or vegan kind of thing. They
He
consume lot of the things. Yeah,
except for he doesn't eat
yeah.
egg or non-veg.
So whether they in vegetarian they consume milk or not, whether they're consuming legumes or not, is there any sprouted thing that they actually? Examiner, the old examiners come no, so they are very very much interested in nutrition aspect. So they ask you how much vitamin
Yes.
B12 in 1 liter of milk. They'll
Yes.
ask you how much vitamin B12 in 100 grams of legumes.
Got it.
Getting my point. So
Yeah,
you should
he's
have
a
a detailed
vegetarian who
dietary
consumes
history.
milk and milk products. Doesn't
How much?
even
How many times a
uh,
week?
milk you mean to
So,
say how many times?
yeah, so actually we are not just bullying you, please. Na, don't take
It's
it
okay, I
Don't
wrongly.
mind.
understand, ma'am. Yeah.
These are the things, because see, if your
Yeah.
history is not giving enough information, you will be, I told you, pulled and pushed to different corners and will be asked different questions
Yeah, yeah.
in the myriad of,
So that
different.
is like, and again in the diet along with go back. It's not complete. So in
Uh,
diet, it's
Flight control is
not
not
only
what
diet,
we have.
appetite. Appetite is
Yeah.
equally important. In chronic
Appetite
progressive,
can
all the
put it as normal.
yeah. So
Hey,
it's a normal.
Rohit, I see a person with so many family history being suffered, died, and he is having the disease which is inherited, and you must have many of people must have told him that you are having a degenerative inherited ataxia. Do you think he must be sleeping normal?
Sir,
It must have affected his psychologically, he must be depressed, very apathetic, aloof, emotivational. If I would have got this disease, I would have been like, gone out of mad and I've become, you
he's
know, I
very
would
much
not have normal
motivated
sleep, I would not
individual,
get
sir.
normal appetite. How
Understood.
can he have normal sleep, man? Did you
He's
ask history of sleep, man? You felt
I
he might be sleeping normal and right.
James Sir, he's a very like motivated individual. He's gone through a lot.
Okay.
He has, I mean, he has seen his younger brother, he has taken care through. He told me, unlike the younger brother, is not.
And your written alcohol consumption plus, what does that
Sir,
mean?
he consumes very occasionally.
If you consume,
Once
so what kind of alcohol, how much amount of alcohol daily, once in a week? When was the
drinks
last
beer
binge drinking
very,
alcohol? Alcohol is one of the important substrate in this history, right? Because
yes.
chronic alcoholic intoxication also produce this ataxia, right?
He stays, I mean, he doesn't, he drinks only once in 3, 4 months, once a bottle of
Okay.
beer. That's it. That
Mhm.
is why it was difficult to quantify, so I mentioned that.
But you're supposed to write
Chicken.
history. History you have to write.
Hmm.
Occasional alcohol, he drinks 8 ml or one, whatever, like they say, na?
That's
One quarter,
okay.
one peg, two peg,
Hmm.
brandy,
Hmm.
whiskey. Last drink was so many days back. Those kind of things is supposed to write the history.
Hmm. He consumes beer once in 3, 4 months and a bottle of beer, 350 ml. That's it. That
Okay.
not a regular.
High risk history is also you should take.
No.
We are we are presenting a case of cerebral ataxia. So the history of the high risk
Hmm,
behavior,
hmm, hmm,
any
hmm, hmm,
needle needle injections or like the other
hmm, hmm,
history, because HIV or the
hmm.
syphilis, all are the causes of this chronic ataxia, no? Or
I
cerebral
asked for
ataxia.
any drug consumption or the distance, but I didn't ask for iris behavior.
What history you will ask for these things?
Uh, with, cocaine, amphetamine, that drug abuse. Yeah, trick,
So
trick.
the injectable drugs,
Yeah.
high risk behavior, blood transfusion. So those histories should be taken, or the history of a recurrent hepatitis or jaundice.
Okay.
They should also come. Okay. Any
Okay.
tattooing is there or not? So they should come.
Okay.
Yeah,
Okay.
go ahead. So what information do you derive from this family or the pedigree chart?
There's a vertical transmission ma'am. Two generation have been affected.
So the
Each
third
generation.
generation history was not there, or were we not able to drive, or no one knew what was there? I mean, the second generation is having so many patients. The grandparents, did they do, whether they did not
They,
have any history, or it was not known?
when it was not known, so the individual didn't know the complete category. That's why I have to
Age
take
of
only
death,
the
did you ask? Did you ask age of death in
age of death.
grandparents?
Grandparents, they told I asked symptomatically, clinically, at what age did they have similar complaints? They told they were natural death, they were like 65, 70 years old. Even his father had onset of symptoms at around age of 40. He expired at 70 years. But
Okay.
only
So what information is there from this pedigree? What information? You just said the positive family history.
multiple generation being involved and vertical trans both in favor of autosomal dominant sort of an inheritance.
See, so from the pedigree we see whether it's a consecutive generation or we are skipping generations.
No skip
Okay.
can
So if there is no skip generation, so most likely we are dealing with a dominant thing. Then the male and female both are involved.
correct. Okay.
Okay, so that means most likely we are dealing with autosomal. Then there is a male to male transmission.
Correct. Yes, ma'am.
So most likely we are dealing with an autosomal. The females are not transferring, but they are having the disease.
Correct.
And the age of all these siblings should also be written. And along with that, there is a history of anticipation. The father had history at the age of 40 years. So you have to ask at what was the age of onset in father, because your patient is having the history of 37 years and father died at almost 40 years. So 3 years doesn't mean anticipation.
No, 40 was the onset for his father. Father died later.
Oh,
Son
father
of
died later. Onset was
uh,
40. So
yeah,
still the anticipation is not that strong.
brother had it at 30 years and he expired at
Mhm.
35.
It's not that strong.
The
So
younger brother.
when you tell in history in your summary, you should say this thing. That the patient is most likely having the autosomal dominant kind of inheritance, because I think the both male and females are involved and there was no skipping of generation.
Yeah, ma'am.
Okay, not only the positive family history.
Okay.
So now you summarize this case.
A 40-year-old gentleman with complaints of gait ataxia and dysarthria of 3 years
No.
duration.
What kind of ataxia? Please confirm now here.
Cerebellar.
Is it a cerebellar, proprioceptive, combined?
So likely cerebellar ataxia with dysarthria of
Then what about that first line you have written? He was having increased imbalance under darkness.
with it's a combination of cerebellar and sensory history wise with speech disturbance in the form of dysarthria with a significant family history of multiple individuals being affected.
So actually now you will summarize this. A 40-year gentleman with progressive history of a truncal ataxia, most probably the cerebellar, along with there might be a component of proprioceptive or the sensory ataxia as well. I need to confirm in this my examination. And the dysarthria, then in the dysarthria, if a patient was having cerebellar or spastic, what kind of that? Then you will say dysarthria probably of this kind. Okay.
Right now.
Along with a significant positive family history, both in the male and the female. So most likely the autosomal dominant one with negative, important negative one. What important negative? No appendicular involvement is there, or there is no involvement of a, what
No
other thing?
involvement.
So
Because
along with the positive, the significant negative with occasional alcohol consumption with no substance abuse or no high risk behavior. So now you will go for the functional anatomical localization.
functionally, ataxia mixed cerebellar and sensory.
The cerebellar ataxia, and among the cerebellar ataxia from the history it seems to be truncal ataxia. So that's why my anatomical localization in the cerebellum is most likely the Vernian part is more involved than the other. Okay. Anything to add, sir?
Yeah. So please go back to the slide. So when you write at the end of history, there are four aspects, right? One is what are the anatomical attributes for the neurologic problems the patient has? Anatomical attributes, what are the structures in the neuroaxis are involved? Second is functional deficit. Third is pathological diagnosis. Fourth is etiological diagnosis.
Sir,
So what is your pathologic diagnosis? You say because of the family members being affected, it is degenerative inherited. Okay. What is the etiological diagnosis?
etiology is genetical, genetically mediated, autosomal
Which one?
dominant anatomy.
In that, which one? Autosomal dominant ataxias. What are the? How do you classify ataxias? Anita Harding's classification of ataxias. Yesterday he said, na, Ramanan, very
Yes,
nicely depicted all the classifications of ataxias.
just
Spinous, cerebellar.
autosomal dominant and recessive with a known genetic abnormality and encoding known genetic
No, you tell
mutation
in
and
your patient. You tell in your patient. What is your patient saying?
uh, genetically, I mean, other family members have, so there must be, since there's a significant family history, they'll have known genetic
You have to read,
cause.
Rohit. Go ahead. You have to read. Go ahead.
So we'll go into the examination. Okay? A moderately built and nourished individual, height 168 centimeter, weight of 70 kg, BMI of 24.80, this neck length was 18 centimeter, and height to neck ratio was 10.52. There was no paler reflux, sinuses, clubbing, or lymphadenopathy. We had mild scoliosis with convexity to left, no press level. Pulse was 80 per minute, regular, all peripheral pulses were felt. And BP was 128 by 78 millimeters of mercury on lying down, with no postural drop at 1 and 3 minutes. We had capillate spots in right and left axilla, about 3 in number, measuring 3 into 2 centimeter, and there was an hypopigmented macule in the right loin region.
Do you
Go
have the
back.
photo of
Go
it?
back.
Photo.
I couldn't, I had given a, the patient was physically present when he was there when we presented. I had called him, I was not able to get fixed, so we were not taken fixed actually last we presented.
So, Dr. Rohit, whether this is scoliosis is because of skeletal deformities or it was because of muscular involvement? Because in history we said no, that he was having difficulty in coming down.
Ma'am,
How will you differentiate?
there's an examination whether the skeletal or it was a mild convexity. So
No, whether it's
muscle,
mild or moderate doesn't matter. Whether it is because of a fixed skeletal deformity, because of a vertebral alignment is defective, or it's a muscular problem. How will you differentiate in examination?
don't know. Definitely.
Okay, so what happens? You ask them to touch their feet or to ask them to bend forward. Okay.
Okay.
So in patient with a fixed skeletal deformity, it will persist as same.
Okay.
It won't disappear. But the patient with a muscular weakness, your scoliosis will become normalized. It will disappear on when they try to touch their feet,
Okay.
when they bend forward. So then you will differentiate whether it's a fixed skeletal involvement or a muscular weakness is there. Okay. And now you tell me, how do you describe pulse?
Pulse rate, rhythm,
Then
volume,
then
radio femoral delay,
hmm.
and we look for all the peripheral.
Why your pulse is important in cerebellar case?
Ataxia, telangiectasia, can have some lung malformation or and they can have cardiomyopathy. Frederick ataxia can have
Yeah, you
cardiac
can have
involvement.
cardiomyopathy. Okay,
Ma'am?
so you should have complete. Yeah, the patient can have cardiomyopathy.
Yeah.
Your patient might have atrial fibrillation. He's just having multiple showers of stroke. And he may come with a multi-infarct status, and that's why he's coming with the cerebral ataxia. For example, if there is no family history.
Correct.
So the general examination must be complete. There is no JVP you have written. And the pulse should be completed. Yeah, JVP is not there, no? So it should be there. Okay?
Yeah.
So the pulse should be complete. What is the rate? What is the rhythm? Whether it's volume. There is no radial or radiofemoral delay, and all peripheral pulses are palpable or not. So that should be complete examination. General examination must be complete.
Okay. Okay. Yeah.
Okay. What
So,
other thing you will see?
Yeah.
in cardiovascular, we can look for this apical beat. Cardiovascular and respiratory system was essentially normal. What I look for in cardiovascular system was apex beat. If in case if a cardiac involvement is there, likely cardiomyopathy, they can have lateral displacement of the apical impulse. So it was within 1 centimeter of the mid-clavicular line.
I think it's in next slide. The slides are not moving.
Side control is not with me.
Rohit, that cephalite spots, what you have written, is it significant? Would you say
Sir,
significant?
if you look at the classification 330, 430, it is not significant. It is only 2 in number.
Oh.
So it was not significant, sir, but we wanted to know if there is when it was there on clinical examination. So I had to.
Okay.
So coming to the nervous system examination.
You are supposed to look at there are 6 things: skin, hair, nail, tongue, teeth, tonsil. These are the 6 aspects you are supposed to write in the general examination. How is the skin looks like? Hair, is there any graying or premature graying or any altered pigmentation? Skin, hair, nails. Nails, you are supposed to document any altered pigmentation, any specific lines or any angle, periangle lesions or nail. Tongue, you're supposed to look at tongue, teeth, tonsil. These are all skin, hair, nail, tongue, teeth, tonsil. You're supposed to write in a verbatim in detail.
Okay.
Okay, go ahead.
Coming to nervous system examination, higher mental function is scored 30 on 13 mini mental status examinations on the day when we did the examination. And speech, we had dysarthria. It was more of spastic dysarthria.
Spastic?
Yes, sir. We had that staccato.
Do you have the video? Do you have the video?
I don't have the video. I was not able to get the video because with short notice. I contacted the patient, but I was not able to get the video.
Okay.
Visual acuity was normal in extraocular movement examination. He had bilateral.
Wait. In case of cerebellar ataxia and second cranial nerve examination is very important. What all you will see?
Visual.
Second cranial nerve. The optic
examination.
Visual acuity, color vision.
Yeah, why visual acuity is important in cerebellar, especially autosomal dominant cerebellar ataxia you are having, no?
Ma'am.
Yeah. What are the ataxia with visual impairment?
So certain types of spinocerebellar ataxia, they have optic nerve involvement and the other. Vision.
SCA7 is having. And what are other ataxias with this optic atrophy?
The mitochondrial disorder.
Yes, mitochondrial ataxias. And are there any deposition disorders?
Iron accumulation, neuro deposition.
What happens in Niemann-Pick's? What happens in Tay-Sachs?
We can have this cherry red spot in Niemann-Pick's. Fundus examination.
So second cranial nerve or the optic examination should be complete in cerebellar ataxia. You would look for telangiectasias first. In external cranial examination, you look for cornea, you look for KF ring, then you look for cataract is there or not. Then after that, you will see for visual acuity. Then you will see whether there is a color vision impairment or not, whether you are getting any fundus involvement. Fundus is very important. The optic atrophy, retinal degeneration, retinal pigmentation.
Okay, I've done
Yep.
fundus. Must mentioning
Uh,
it.
So
Fundus
the
examination.
detailed examination must be there.
Okay, right.
Okay.
We'll mention.
And then, yeah. And then third, fourth, sixth cranial nerve, how you'll write?
We'll look for the extraocular movement charting.
So how do you check for extraocular movement?
So that H method.
So what was there in your patient? Whether it were normal or they were having some impairment?
Only the convergence was impaired.
Convergence or the function of medial rectus? What was impaired? Whether adduction was impaired or convergence was impaired?
I mean, adductions was only the convergence
So
insufficiency.
So extraocular movement is not, see, there are two different things. The extraocular movement and the convergence are two different things. The convergence comes under your supranuclear control.
Yeah.
Okay, so there is a separate thing. One is the extraocular movement. You will check for your adduction, abduction, whether they're able to elevate it or whether they're able to depress it. So all those comes under the extraocular movement. Then comes your supranuclear. What are the supranuclear eye movements?
Convergence.
You're written, Allah.
Pursuits.
They are saccade, pursuit.
Pursuits and convergence.
Saccade, pursuit, vergence, OK, and VOR. Okay. So what happens to saccade in case of cerebellar ataxia? Go back.
What is pursuit, Rohit? Pursuit.
Slow. I mean, watching object move slowly. So. Pursuit is that.
So can you tell the pursuit pathway? Smooth pursuit pathway. And what is the role of cerebellum in the production of smooth pursuit pathway?
It's in coordination.
Okay, go ahead. What is saccade?
Saccade is fast to and fro movement of the eye to watch a fast moving object.
You're supposed to know all these things, Dr. Rohit. What is pursuit? What is saccade? What are the, there are some mechanisms of saccades, pulse, step, neural integrators, and horizontal saccade, vertical saccade. There are different kinds of, so much details they ask in exam.
Yeah.
It's very tough. If someone asks about eye movements means, is you're gone in the exam. Like they ask much detail, especially in the long case. They ask all about burst neurons, neural integrators, and omnipath neurons, or saccades, and smooth pursuit, unilateral, bilateral. Why is it ipsilateral pathway? You're supposed to know all the saccade pathways and pursuit pathways. Okay.
Yes.
Please read it.
I had read it a long time back, so I'll have to refresh.
Okay. Oh.
The other cranial nerve examination was essentially a normal.
Why the fifth cranial nerve examination is important in your patient?
Fifth cranial nerve.
Yeah, in cerebellar case, fifth cranial nerve is very important. Why?
The track, the nuclei of the fifth cranial nerve is a long.
Yeah, see, in cerebellar cases, there are some treatable causes like CVJ anomaly. So, what are the nuclei of fifth cranial nerve?
Sensory nuclei for
In CVJ anomaly, why there is involvement of a fifth cranial nerve? What happens?
the long tract sensory nuclei of the fifth cranial nerve might be affected because of the permeation, CV junction anomaly.
Okay, so go back and read it. There
Okay.
are three nuclei, the spinal nuclei one. One
Okay.
is your principal motor nuclei. Okay, one is a principal sensory nuclei, and the rest is a third, that is the spinal nucleus. The
Okay.
spinal nucleus extend from where to where?
Hmm.
Spinal nucleus extend from where to where in brain?
Mm. Yeah.
So it extends from your midbrain up to your
C2, I think.
C2. Okay.
Okay. Okay.
So what happens in CVJ anomaly? There is involvement or there is this compression over this spinal nucleus. So that's why they develop a involvement of a trigeminal nerve in those patients.
And there
Okay.
is a directional
So-
involvement also. If it is a lesion is coming from bottom to up, you have certain kind of involvement, perioral to perioral. So
So
there's kind of pattern.
what are different patterns over there? What are different anatomical variations in there in fifth spinal nuclei? So that should also be known. Okay.
Right.
Why seventh and eighth is important?
Seventh, seventh, cerebellum.
See, neurosurgical cases, they refer to you, or you may have to, you may get to see some cases, mass lesions at CP angle.
Sir,
Seventh and eighth, they can produce with cerebellar symptoms, right?
vestibular
What is the canal to which they pass the internal acoustic meters? Huh? Am I audible, Dr. Rohit?
Yes, sir. Yes, sir. You're audible.
Please answer if you're yes or okay or not and all.
Okay. Canal, you told you asked, is it the Dorello canal?
Oh, please don't go to Dorello, yeah.
Okay.
We are at seventh and eighth internal
Yeah,
acoustic
Dorellos
meters.
is for sixth.
Dorellos
Dorellos
is
is for
for
sixth. Sixth.
Oh. When it is involved, that system in patients, if they have raised ICT, as a fast localization sign in patient raised ICT. Okay, go ahead.
Coming to the motor system examination, muscle bulk was normal, sir, in all four limbs. Tone was increased in all four limbs.
What is the classical tone abnormality in a cerebellar disease? In general, in cerebellar disease, what do you get?
Hypotonia.
Why? Yesterday, Ramanan has described the mechanism.
But,
Were you there in yesterday's class, Dr. Rohit?
no, sir.
You should have attended, man. You must have learned all these questions because he describes many things. Acute lesions cause hypotonia, chronic lesions become normal.
Sir.
Mechanism of hypotonia, gamma afferent and loss of gamma afferent, gamma motor neuron facilitation, gamma. He has written, you see.
Sir,
Please, you're supposed to read, man. And you written dystonic posturing noted in both hands and feet.
We had like the posturing of hand and feet was noted.
Okay, wow.
Power was 5/5 in all four limbs. Bilateral plantar was.
Is it focal dystonia or multifocal or generalized?
Sir, it was
What kind of
focal dystonic posturing.
Bilateral hands and bilateral feet, is it focal or multifocal or generalized?
Multifocal.
When you
What
say
is
generalized
classification?
dystonia, classification
What is
dystonia.
classification?
More than three anatomical contributors.
Anatomical classification of dystonia, Dr. Rohit. When you call it as focal, when you call it as multifocal, and when you call it as generalized, and then the segmental one. How do you say? So the focal is only one body part. Okay. The segmental is the two contiguous body parts. A multifocal is non-contiguous body parts. More than two non-contiguous body parts is multifocal, and the generalized is when there is involvement of a trunk or the lower limb also, along with some other body part when there is involvement of a trunk. Then you
No,
call it as a generalized. So you said your patient is having in both hand and both
both
feet.
lower limbs and lateral. Yes.
You should put an
There are
image, video or image you should have put.
video I was not able to get. So yesterday only
And
I done that.
the thing is, if your patient is having in dystonia in both hand and feet, they must be complaining in history also.
Mm-hmm.
Mm,
Hand mouth coordination, they must have
It
been
will
some
be
history.
disturbed.
mm.
I mean, how can a person who is having dystonia in his both the hands, they're not complaining in history? They will be
The
complaining
historic posturing was there on examination, but historically we didn't give.
Okay.
Okay.
Deep tendon reflexes were 2+ and 2+ biceps, triceps, brachioradialis. Only the knee reflex was 3+. Bilateral plantar was extensor. Then
You
gait,
said spasticity in the limbs and reflexes are 2+.
yes sir.
Spasticity in all 4 limbs, but reflexes are 2+. It's not going. Yeah, the things are not matching. If you are writing spasticity, the reflexes should have been brisk, right?
Sir, only the knee reflex was brisk.
Knee even otherwise also
3 plus knee is normal.
normal.
mm,
Okay. And along with that, when the plantars are extensor, there is hypertonia, the reflexes will also change.
but
And what are other UMN reflexes that you checked? What other reflexes you will see in this patient? What is
jaw,
Hoffman?
what is?
Hoffman reflex. What is Wartenberg
Hoffman
reflex? What are
sign,
they? How do you
Wattenberg.
check them?
Often is the upper limb equivalent of Babinski. The distal interphalangeal joint we try to click and see.
What
And
happens? What you will check
you
when it
use
is called as positive?
it's also like the distal interphalangeal joint will flex. If
What?
it is,
Which distal interphalangeal joint?
apart from the fingers that we are doing, other fingers also will go
So the
into a
important so the
flex.
important is the thumb and the index finger.
No,
Okay.
someone index.
Yeah, thumb and index. And how do you check for Wartenberg? And whether Hoffman is equivalent of plantar or Wartenberg is equivalent of plantar?
Mm, Wattenberg.
Wartenberg, huh? So how do you check for Wartenberg?
Wattenberg is
And what? Okay, you have written as 2 plus. So knee was only 3 plus, or whether there was a crossed hyperreflexia also there? Was reflexogenic zone was normal, or there was an increased reflexogenic zone?
reflexogenic zone was normal.
Okay. How will you differentiate between striatal toe and extensor plantar? And why there is a striatal toe in dystonic patient, or in case of advanced PD or extrapyramidal disorder? That is mechanism behind that.
Mm,
Your
The
patient was having foot dystonia, no?
uh, it is to do with the antagonist muscle being overacting. I don't know the exact term.
How you will describe dystonia?
What is the mechanism of dystonia?
Posturing movement.
What is the definition of dystonia? Okay.
Abnormal posturing of a body part.
Just read this all, okay? The
Okay.
definition in movement disorder is very important. And if you know the definition, you will be able to differentiate an OPD
Okay.
between different movement disorders. Otherwise, it's very difficult. Okay. And in
Yeah.
Hoffman, someone asked in Hoffman, actually check it in the middle finger only, and then you see the flexion and the adduction of your forefinger, the first finger, and your thumb. Okay.
First and thumb. Okay.
Yeah, first and thumb. This Dr. Ajay must have asked. Okay, please go ahead.
Mm. Next slide, please. The sensory system, there was no obvious deficits. Autonomic
So
nervous
in history, you said your patient is having worsening in
and
dark.
dark and
Yeah. So in sensory system, what things you will check?
proprioception and the vibration sensation.
Okay. And how do you check for proprioception at foot? At ankle, how will you check?
You
Okay, how do you
either
check proprioception? Just tell me, how do you check proprioception?
you load the great toe. First, initially you show the patient like up and down movement, the reflection and the extension, and then you will tell him to close his eyes, and you will tell them you will be doing the movement, and you'll have to tell what is the position that he is able to perceive, whether it is down, up, or in neutral position.
Then?
And then you do it like for at least 10 times, and the error should not be more than 3 times, three in 10.
So you have to stabilize the joint
Hmm.
with one hand, and from the other hand, you will move it without touching other fingers or other toes.
Okay.
And then you have to ask them whether it is down, whether it is up, or whether you are moving or not moving. Which
Okay.
is more sensitive, the movement or the up and down?
Hmm. Keeping neutral. This is
No, I'm asking in the proprioception, there are two things. The one method is you move the toe and you ask them whether it's moving or it is at rest. Okay.
correct.
And the another is you ask for the joint position. You ask them whether it's a down or up, which is more sensitive.
Them telling whether it is up or down, then neutral.
The sensitive one is the movement.
Okay. Hmm.
As soon as something touches to your body or something comes in contact or it moves down, you get it very fast.
Okay. Hmm. Hmm.
Okay. The movement is sensitive and the up and down is more specific one.
Okay. Got it.
Okay. And how do you check it at foot?
Foot again, when you stabilize the ankle joint and you do dorsiflexion, plantar flexion, you do the movement and you tell the individual not to do. He
So your
sees
foot
it like
must
that.
be in air. Your foot must be in air.
Foot must
You
be
will, in air. You will lift the foot
in the
above
air.
the ground.
Okay.
Yeah.
Okay.
You will lift the foot above the ground.
Okay. Okay.
Then you will hold it from the ankle. You will just stabilize it and then you will move it from the other hand.
Okay. Okay. Got
Okay.
it.
So your sensory system examination, you should write it again complete. Your
Okay.
crude
What we
touch,
did.
fine touch, crude touch, fine touch, pinprick, vibration, joint position, joint proprioception, then the secondary, your this cortical sensations.
None. Hmm.
What are cortical sensations? Just name them.
I mean, 2-point discrimination, graphesthesia,
Hmm.
stereognosis,
Hmm.
Baro.
Barognosis,
Ah.
yes. Tactile localization, tactile discrimination.
Tactile discrimination, 2-point discrimination. Yeah.
Hmm.
And
Okay. And in autonomic nervous system examination, in bedside quick test, what you will see?
sweating abnormalities, and you look for postural BP issue and heart rate variability with respiration.
Heart rate variability with respiration and so okay, go ahead. You read
BP
it.
heart rate.
Read it, okay?
Yeah.
Read it in very detail. It won't work.
And don't write like this kind of blanket statement, no deficits. You cannot be dogmatic in examining the sensory system and say no deficit in entire sensory system. So much, madam, discuss. And you are written one word, no deficit. It's like you are closing the chapter not to discuss further. Right, what happened to the crude touch, light touch.
Okay.
Go in
Okay.
depths, superficial
Yes, sir.
sensory symptom, deep sensory symptoms system. Divide it and write it. It is a very good habit for
Okay.
lifetime learning and practice. Okay.
Okay.
Okay. Go ahead.
coming to the cerebellar system examination, there was bilaterally finger nose test was impaired. Heel chin test was impaired bilaterally. Uh, Romberg test was positive. Tandem gait was impaired, and the rebound phenomenon was positive, and he had dysdiadokinesia was there.
So
And,
again, if you have written the cerebellar examination, try to write
ma'am,
them either in the first in the upper limb, then in the lower limb. I mean, we won't be going to jump from the upper limb to lower limb just drastically, no?
okay, separate for upper limb
So
and lower
yeah,
limb.
so or
Okay,
at least it will be orderly for someone to see, no? So finger node
okay,
test at the same time you write that is dysdiadochokinesia, then the rebound test.
ma'am.
Okay,
Mm.
go back to the cerebellar examination.
Yeah, we are in the same slide, ma'am.
Eye signs you have not written.
Yeah,
Eye signs.
Hmm.
So we had spoken about that
No, cerebellar you are
nystagmus
supposed to
and
write
there.
eye
Okay.
signs. What are the different kind of eye movements you get in a cerebellar disorder? Huh?
So this downbeating nystagmus in
Ah,
CVJ anomaly.
okay. So you're supposed to write how are the pursuit abnormality, how is the saccade,
Okay.
what happens to is there any gauge work nystagmus, is there any rebound nystagmus?
There in the third,
Uh,
fourth, sixth year, we had mentioned sir, bilateral gaze revoke nystagmus and
hypermetry saccade. No, in cerebellar you're supposed to
okay.
document again eye signs.
Okay, right, sir. That I've missed here.
Mhm.
okay, please go ahead.
Gait, he had a wise stance gait, was dragging of
Again, wait. This is to all the students. Whenever you're starting the gait, start from the time your patient stand from the sitting position. Don't just directly jump onto the stance. Just say how your patient stand from the sitting position. Then you tell about one thing is a station, another thing is a gait. Or when the patient walks. So how is he in the station or in the standing position whenever he's standing? Okay,
stay
at that time
right.
there is a station. Station is called when your patient, as soon as he stand from the sitting position. So the condition of the patient whenever he is standing. So at that time, whether he is having in wide waist, whether he is swaying to either side,
Okay.
as soon as he stand. If you see the patient of cerebellar ataxia, they just start swaying as soon as you make them sit, or as soon as you make them stand, they just start swaying to either side.
Okay.
So the station is equally important.
Mm.
Okay, then you go on.
Station, he has a wide based on standing, he has a wide base station, and
Yeah.
there
Was he
was
swaying to either side?
yes, ma'am. The
He
swaying
was
towards either
swaying. As
side,
soon as he stand, there was a swing. So there was a
swaying,
truncal involvement. No?
mm,
Okay. Then you start it from the gate.
swaying, and wide stance gait, and there was dragging of both the lower limbs while he was walking, and there was reduced bilateral arm swing.
What is the meaning of dragging over here? What do you want to say?
So, increased tone because of the lower limb spasticity. There was some amount of dragging that was
So here you have to describe whether patient keeps his heel first, whether he is keeping your toes first, whether he is
okay.
slapping on the floor because of that. I mean, that toes first can be in UMN and LMN both.
Okay.
So whether he was lifting his leg more and he was causing a slap and that's why he was keeping his toes first, or whether it is because of whether he was just directly just keeping his toes first, not flexing at knees.
See, one
Getting my
statement you have
point.
written everything, Rohit. Pyramidal, extrapyramidal, cerebellar, everything you have written one line. Dragging, pyramidal. Extrapyramidal reduces flowing. Cerebellar, wide stance. So many things in online you are supposed to describe what madam is trying to say. Please learn.
Okay.
Okay. And dystonic posturing, what kind of posturing he is having? Whether it was increasing in walk, whether what it was at the rest, what was happening when he was trying to walk back. Was it initially there or not? Was it worsening as soon as the patient continues to walk, or does it improve? If you do the distraction test or the two task test, whether it improves or it worsens. Okay. Then again, all the maneuvers you have to say in gate, your Rombergs, it will come in station. If you have already described, that's fine. Otherwise, it will come in station. Then your pull test, your tandem gate, your tandem station, then tandem walking. All that will come, and then pull test. Okay. And in a
Rohit,
spine examination, Dr. Rohit, Dr. Rohit, sir,
Yes,
am I
yes, ma'am.
audible?
Yeah, audible, ma'am.
Yeah. Okay. Yeah, please don't get disheartened. No, this is just to
No,
tell you
ma'am.
so that you
I'm noting
don't.
down so that I'll.
Yeah,
you're in
so that
first
you
year,
just
second
don't
year,
get upset.
Rohit, fine
Second
year,
year
which year?
ending, sir.
Second year
Second
ending.
year.
Okay, you
Yeah.
have one more year to improve. Don't worry.
Yeah.
Uh,
Second year MD or DM?
DNB Neuro, ma'am.
DNB, neuro.
DNB neuro. No,
Ah,
fine. That's I
ah.
thought so. Okay. Yeah, and then your spine examination. So spine examination again, is there any gibbous, kyphus is there or not?
You, okay.
Okay.
Structural
And yeah,
deformity.
the structural thing that will
Okay.
come. And
Okay.
then it will come your scoliosis. And as I told, whether it's a fixed scoliosis or it was
Okay.
disappearing when the patient is bending forward or not.
Okay.
So all that thing should come. Okay.
Okay. Right now.
Again, it will your directly won't jump onto differential diagnosis. What things did you add in your examination added to your history? What things
There
you
was
got extra?
no, say, we ruled out sensory ataxia.
Why ruled out?
Yes.
You're written a rhombus positive?
Yeah.
Huh? You're included, no?
I mentioned, sir, Rombox is positive,
Positive.
but
Yeah.
most of
So,
the cerebellar,
no. How do you Romberg test and how do you interpret it?
uh, see, we make an individual stand with both the foot close by, touching each other,
So
and first with eyes
I'm again
open and then
explaining.
with.
Okay. Yeah, just listen to it calmly. I'm just again explaining. First, see how your patient is standing normally.
Hmm,
Okay. Then you ask in their normal stand or in the normal station to close their eyes. And then you will
okay.
see whether the patient is swaying or not.
Okay.
First thing. Then you will take them actually to the closed feet. Ideally, I mean, in the modification thing, you should make them a bare foot. Okay.
Okay. Hmm,
Close
hmm,
both the feet, outstretch their hand, and then you will see whether they're able to maintain posture or the balance during that position or not.
okay. Hmm.
If they are swaying in the, if you said in your gait, as soon as the patient was standing, he was swaying.
Yeah, swing, yes.
Okay. So what will happen when he will close? Whether it's a disproportionately worsening again,
Hmm, hmm.
okay, or whether it was just a similar swing he was having.
Okay. Okay.
So if there's a
Understood.
similar swing he is having at that time, then it's not a Romberg's positive, it's Romberg negative.
Okay.
If a patient is already swaying as soon as he's standing from the sitting position, then in Romberg's he will definitely be swaying.
Swing. Hmm, hmm.
Okay, so Romberg will be negative in that case.
Okay. My hand should be outstretched.
Yeah, hand should be outstretched, they should be outstretched.
Okay.
Okay, so just test it.
Hmm, hmm. I'll-
Okay. So I don't know what was there in your patient, but most
Hmm,
likely if your whole sensory examination was normal,
hmm.
all this posterior column and cortical
Yes, ma'am.
sensations were
It
normal,
was
then
normal.
it should be normal. It should be negative.
Okay.
And how will you eliminate the vestibular component from the cerebellar or from this proprioceptive? When doing a Romberg test,
How do you take off the vestibular?
how do you take off the vestibular? Vestibular is intact, no, whether you close your
Hmm,
eyes or open your eyes.
hmm. Uh,
Okay, so read it. Okay.
okay. I'll read
Yeah.
it. About vestibular elimination.
Go back. Yeah. So now how will you summarize your case? What things I did?
Uh, a 40-year-old gentleman with complaints of ataxia and dysarthria of 3 years duration with significant family history and with no history of consumption of any no history of any high risk behavior or drug intoxication. Clinically, he had clinical examination was more suggestive of cerebellar. His clinical examination, he had cerebellar sign positive, but
So you had three systems. You got three systems extra, no? You got extra pyramidal that you didn't
Yeah.
tell in history. It would be there in history. Definitely there is we have not taken the detailed history. So the extra pyramidal you have got. You have got the motor one, the spasticity.
Mm.
Okay. And again the sensory we don't know whether it was there or not.
sensory.
Okay. So you have got three more things along with the ataxia. So you are not dealing with an isolated ataxia. You are dealing with ataxia plus something is
Yes.
also there.
Mm.
Okay. So now where will you localize to your cerebellar ataxia? What part of the cerebellum are involved in your case?
The midline vermis and vermis is involved.
Why only vermis? Your finger nose test was positive. Your dysdaticokinase
so it's a
was positive.
pan-cerebellar involvement.
Why pancerebellar involvement?
Both central axial and appendicular involvement is there examination wise.
What are parts of cerebellum? How do you classify cerebellum? Anatomical classification and functional classification. How do you classify?
Functionally, rheocerebellum, neocerebellum. Anatomically, central vermis, then anterior lobe, posterior lobe, and floconodular lobe.
Tell me again the functional one. What did you say? It's neocerebellum and then? It's a pontocerebellum or the cerebrocerebellum. Okay, it's a vestibulocerebellum and it's a spinocerebellum. Okay, so what is the function of spinocerebellum?
Balance.
It's an axial control. The spinocerebellum is for axial control. What about flocculonodular or vestibulocerebellum?
Appendicular.
Oh, flocculonodular.
No.
Flocculonodular is along with vestibular system, no? Okay. Don't worry. Don't get just confused. Just go ahead and just be calm and just read. Okay. You will just again retrieve everything.
Vestibulocerebellum.
Don't worry. Yeah, don't worry. So you have to see which part of cerebellum is involved. And in extrapyramidal, again, what kind of disorder you are getting? You're getting hypokinetic or you're getting hyperkinetic?
You had dystonia posturing, so more of hyperkinetic.
You are getting both. Your patient had reduced arm swing.
Reduce something you written, no? Hypokinetic.
Combination of hypo and hyper.
So it's both. Combination of hypo and hyperkinetic. What kind of hyperkinetic?
Dystonia posturing.
It's a multifocal dystonia that you were getting.
Intermittent posturing.
Okay. So again, you have to see. It's only the action dystonia or it was a resting dystonia.
Okay.
Then you will see what parts are involved.
Mm-hmm.
Okay. And again, in the hypokinetic, what structures will be involved? The third thing you see, the motor system. You are having spasticity. So what do you think? Why your patient is having spasticity?
Pyramidal tract involvement, even in
Where in pyramidal tract? Pyramidal tract goes from where to where?
Motor cortex till
From which part of motor cortex? Where it is localized?
Supplementary motor cortex till the spinal cord.
The cortical fibers of motor system origin from which areas?
Broadband area 3. Broadband area.
Which area? Area number?
Broadband area 4 for motor, sir.
Hmm.
How many percentage of fibers originate from the Broadband area 4?
Not sure, ma'am.
Okay. So it's not only from the motor cortex, it's from the premotor, supplementary motor, and along with that, there is an involvement from the parietal and occipital as well. So very
Okay.
few fibers.
Okay.
So from the primary motor cortex, it's only 30%.
Okay.
Okay. So and rest of the 30%, it comes from your premotor.
Okay.
Okay. And the 40% they also comes from your post-central gyrus.
40% and 4%.
Yeah. And rest of the 2 to 5%, they comes from the occipital or the temporal also.
Okay.
After that, what happens? From which layer of cortex it originates?
Bed cell
Layer. Which cortical layer? How many layers are there in cortex?
cortex.
It's 6.
Uh,
Okay. So from which layer? Which layer is for the motor?
Number 5, ma'am.
Yeah, layer number 5. And what cells are there?
The pyramidal bed cells. Pyramidal.
All are not from the bed cells. How many percent is from the bed cells? Okay, you just go ahead. Okay, you just
Okay.
go ahead and you just go home and just read all of these pathways.
Okay.
There is no excuse. In at
Okay.
DM or DN at this level, there is no excuse of not knowing the
Okay.
neuroanatomy up to this basic level. Okay.
Yeah, ma'am.
Yeah. Okay. Then so in that way, go back. So what parts of brain do you think now you are involved? Whether you are dealing with just only cerebellum or it's a cerebellum and other areas are also involved.
Cerebellum, cortex, and because of the extrapyramidal basal ganglia,
Why cortex?
because of the spasticity.
Yes, spasticity can be from the cortex, it can be from internal capsule, it can be from corona radiata,
Ma'am.
it can be from the pons, it can be from midbrain, medulla. Above the spinal cord, everything is pyramidal, no?
Mm.
Okay. So pyramidal, extrapyramidal, and cerebellar.
Mm.
Three things your patient is having. Okay.
Ma'am.
And with a degenerative, 3 years history. So most
Yes.
likely degenerative pathology, along with the autosomal dominant.
Yeah, ma'am.
Now you tell us what can be the etiology.
I mean, considering the long duration of illness and family history, significant family history, most likely causes a autosomal or dominant
What are
ataxia.
autosomal dominant ataxias? Enumerate them.
The I mean, one is this spinocerebellar ataxias.
Yes.
Then it,
DRPLA
uh,
and episodic ataxias.
episodic
Okay.
ataxias.
So in what spinocerebellar ataxia you get pyramidal, extrapyramidal, and along with that your cerebellar, along with the cerebellar involvement.
Extrapyramidal involvement is seen in type 7, SCA 7,
Most common is SCA, which one, man?
3.
What are the types of SCA3?
SIF,
3 types, right?
uh, three types asking, sir.
Yeah, go ahead.
I have not read this type.
Okay.
3 types of SCA3.
Most common in India? Which SCA is most common in India? and what is it called? Yesterday Ramanan told all these things.
Mm.
Ka2. It was called Wadia out of Noshir H. Wadias. Remembrance. It was called Wadias disease
Body
because of
with discovered by body.
because of
So we
slow
added
saccades. Slow saccade.
saccade eye movement.
That you should not forget.
Yes.
See, historically, the Dr. Vadia described before your genetic diagnosis.
Yes.
In 19s, he described that there is a patient who are having ataxia in Indian population with a slow saccade, like an oil in a bath.
Okay.
So
Okay.
that's why it is called after his name, the Vadia Ziska.
Okay.
Okay. And after that, all the genetics came and thinking, and then it was confirmed, yes, it is this kind of ataxia is there. Okay.
Okay.
And what is important ataxia that you see in a Caucasian young male with an autosomal dominant history with involvement of significant dystonia?
What is the type of?
What is the other autosomal dominant ataxia in Caucasian patient, middle-aged patient? The patient is middle-aged, no?
Yeah, 40
Autosomal
years.
dominant, middle-aged, developing this kind of ataxias along with dystonias. DRPLA.
DRP. Okay.
Okay. How does DRPLA patient present in pediatric population?
Movement disorders.
Oh, progressive myoclonic epilepsy.
Okay.
What are other progressive myoclonic epilepsies? Just name them, rapid.
This Ludwinger disease.
Unverricht-Lundberg disease. Second,
Ulrich-Lundberg.
yeah, and
Lafora, have you heard?
Lafora's disease.
yes, then NCL,
Hmm.
NCL, and then your DRPLA and
Okay.
siderosis.
Siderosis.
No. I'm sorry, not siderosis. I'm just forgetting the name. Okay, and then there is sialidosis. Yes, sialidosis, and then
Sialidosis.
yeah, and then MRF. So common PME. It's a common PME. More than 40 types of PMEs are there. At least common we should remember. Okay.
Okay.
So what infection? You have kept a differential diagnosis of infection as a cause in this patient. What infections?
Chronic infection like when HIV or in present with a cerebellitis long.
Dystonias?
Dystonias are not explained with this. But post-infectious or para-infectious or autoimmune mediated or paraneoplastic rare possibility.
What paraneoplastic disorders? Which paraneoplastic cerebellar degenerations? Just tell them fast.
Which?
What are paraneoplastic cerebellar degenerations? Common antibodies and common degenerations.
So like anti-U and anti-U antibodies can present.
Anti-U is with which cancer?
Autoimmune. Small cell cancer of the lung.
And anti-U?
Or this ovarian teratoma.
So they are subacute. They are subacute. Usually not of such a long duration of 3 years.
Okay.
And other than that?
Yes. GAD65 antibody can.
The GAD65. Yeah. And if a patient is having this cerebellar dystonia, pyramidal involvement with sleep disorders, what you will think?
Sleep disorders. Multisystem improvements.
Eglon.
Which one, ma? Eglon.
Okay. And the important infection is syphilis, the tertiary syphilis. The infection is written, no, it's a tertiary syphilis. Second, it can be multifocal disease, although it won't be just possible in this, but the multifocal diseases. And among degenerative, although it's an autosomal dominant, but Wilson should also be checked. It's a treatable thing.
Okay.
Then the NCL you will see.
NCL. Neurosis.
Mm, I'm just forgetting.
It is neuronal
Niemann-Pick, sorry. I'm really
Niemann-Pick.
sorry. I'm just getting confused with names.
NPC.
It's Niemann-Pick. Niemann-Pick you
Okay.
should also see.
Okay.
And adult onset NCL, they also rarely present with this ataxia, but usually movement disorders are not that common.
Adult onset.
NCL, adult
Okay.
onset neuronal cerebral lipofuscinosis. They also have this ataxia. They don't
Okay.
have this optic atrophy.
Okay.
But the system movement disorder of dystonia is not that common among them. The onset of illness is also same, but they are autosomal recessive. Okay. Okay. Okay, please go ahead.
And the routine hemogram and metabolic parameters were done, ma'am. CBCRF, telemetry, even vitamin B12, thyroid was done, which was normal. We did
You will
a
just test for thyroid functions, or you will check for anything else also.
anti-TPO.
And anti-TRAB, both.
Okay.
Okay.
The MRI brain was done, which was flashed. This was essentially normal.
Cerebellum normal?
It was normal, sir. There was no atrophy clinic. I mean, neuroimaging wise.
Which imaging is this? What sequence it is?
Which sequence you are showing? Top layer.
Yes, sir.
Is it flare or diffusion?
Sir, diffusion, sir, is 1 minute.
Where we are supposed to see the structural anatomical abnormality? Which sequence of MRI?
Sagittal section, you will see
No,
cerebellum.
which one? We have T1, T2,
T2,
flare, diffusion. Which one? T1 is for anatomy, T2 is for pathology.
Sure.
Flare is for to differentiate between solid and cystic lesions. Diffusion is for vascular. So T1 we are supposed to see. So in T1 you show sagittal.
In T1 sagittal you see.
Second one, fourth image you show, zoom in. Second layer, fourth image, fourth and fifth image. Not zooming in.
Yeah, which is sufficient. Just hold it over here.
Ah.
Yeah, tell us.
We are looking for the grooves or cerebellar.
How do you describe MRI?
It's a sagittal T1 sagittal section.
Showing?
Showing the indentations of the gyres are all well formed in volume.
Are they well formed or are they atrophied? For a 40-year person, is this normal? What do you think? In fourth or fifth image, if you look at the subsequent images,
Ma'am.
there's significant atrophy.
Fourth and fifth is showing
This
dominant
one.
atrophy, bro.
Pan all cerebellar atrophy.
So not only the cerebellar, cortical is also not there. No? The frontal, your parietal, everything is atrophied.
Ma'am.
I mean, you can clearly see these tactile superior inferior colliculi, your cerebellum is so much atrophied. बस हल्का ही कह रहा है यार.
Pan cerebellar atrophy.
Along with the pancerebellar, there is involvement of the cortex also.
Cortical.
Yeah, the frontal, parietal, occipital, every part is atrophied. No? Your patient must be having cognitive involvement. It's very rare that your patient is not having any frontal dysfunction or cognitive impairment.
When is he still working and cognitively?
No, the MMS is not sufficient only in these cases. Ideally, in cases of the cerebellum, function is not only for the coordination and control, it's also for
Okay.
cognition.
Okay.
So in cerebellar cases, you should check for detailed cognition. Ideally, detailed higher mental function must be done in these cases.
Okay. Right.
Okay, at least you should do the MMSE, FAB, and clock drawing.
Okay.
Minimum, it is minimum.
Okay.
Detailed, for exam point of view, you have to do the detailed HMF.
Okay.
Okay.
Yeah.
What else you see? Which
Mm,
part of cerebellum is atrophied? Whether it's a Vermian area, tonsillar area, lateral lobes, what is it atrophied?
It's like pan all of the cerebellum is atrophied.
So if you look in the second row, second image, you start seeing from there. Can you appreciate the Vermian area?
Mm.
And then you look at a paravermian area, and then you come at a lateral cerebellar hemisphere.
Mm.
Okay, so in there, the Vermian is comparatively not that much atrophied. It
Okay.
is atrophied, but the more part is the paravermian and lateral cerebellar.
Okay.
So in history also, the patient must be having appendicular incoordination. It's very uncommon that the patient is having so much dysdiadochokinesia, finger nose test impairment, and the functions and handwriting and all is computer typing and everything is normal. It won't be there.
We'll cross check. But
Okay,
he's still working and he's able to carry out his daily activities of so.
Yeah, he can carry out his activity of daily living. You have to check for instrumental activity of daily living.
Okay.
And then you have to ask them in detail. Do they
Okay.
experience any difficulty or not? Just show us other images.
Next one.
Okay. Sir, anything else should we discuss?
Yeah, madam, I think
We should
2
conclude,
hours
sir,
of
I think.
2 hour long
Yeah.
discussion for a
Yes,
short
I think we
history.
should conclude it now.
Enough.
Yes, sir.
Yeah,
Yes,
Yeah,
sir.
we can conclude
yeah,
already.
2 hours over,
So we
Sailesh.
will conclude this session. Thank you, sir,
Yeah, yeah.
Jacob sir,
Thank
and
you.
Dr.
Soumya,
Soumya
madam.
for
Thank you, sir.
moderating this session. And thank you, Dr. Rohit. So next time, if some final year students are there, they can unmute themselves because I was not knowing that he is a second year candidate. So, okay, we'll conclude.
It's
Thank
okay.
you, everyone.
Thank you. Thank you,
Thank
everyone.
you,
Thank
sir.
you, everyone.
Thank
Thank
you.
you, sir.